Thank you very much, Dr. Gleason. Thank you for giving me the opportunity to present today. Happy New Year, everyone. So we're going to be talking today about germline alterations in GU cancers. More specifically, well, the bulk of the talk is going to be on prostates. We're going to cover urothelial cancers also in towards the end, both upper and lower tract. Like Dr. Glebe mentioned, it's a rapidly advancing field of research. The last 5 years witnessed many advances in that on that front. So I'll start off with a little bit of a historical overview or a bit of a timeline, really. I mean, we all know about the Human Genome Project, which was completed in 2005. A huge breakthrough in that front, which was shortly followed by a rise in molecular testing in urine and tissue for most cancer patients, and that eventually brought us several discoveries. One of the ones that were on the forefront of this were the Brca genes in breast and ovarian cancer, and we know that's been talked about a lot in the media. And then we had the TCGA publication in 2015, which was also a landmark study on 330 prostate cancers. All of them were localized disease. And really one of the highlights of this was prostate cancer is not a very mutated cancer, relatively speaking, compared to diseases like colon cancer and breast cancer and melanoma. However, when this was followed by mapping of the metastatic metastatic prostate cancer in 2015, 2016, which was also a landmark study by Pritchard and the colleagues, it's a lot more mutated at that point in this stage. And this sort of shortly was followed by guidelines suggesting genetic testing in 2017, and in 2019, a lot of guidelines are actually beginning to recommend genetic testing in prostate cancer, which we will cover also in our talk. And as of last year, there's a lot of decision-making and treatment of metastatic prostate cancer that will be driven by these genetic findings. So just a bit of a quick background also. So a germline mutation is abnormally mutated genes that are inherited from parents. So they are transmittable to offspring, and they're in every single cell in a human body. However, a somatic variant is sporadic or abnormally mutated genes in a tumor. So they're only present in tumor cells and not transmittable to offspring. And generally, the cell is equipped to sort of fight and correct DNA damage against sort of mutational insults. And double-strand breaks are particularly hazardous from a DNA damage point of view. And one of the hallmark really of cancer is the defective DNA repair mechanisms in a cell. There are two major pathways, homologous recombination and non-homologous, and a deficiency of these mechanisms was described originally in the Brca and Brca1 and Brca2, and several have followed thereafter. And one of the earlier ones also is the retinoblastoma protein, or the RB1 gene, which is a gatekeeper gene that blocks cell proliferation, regulates cell division and cell death. It's a tumor suppressor gene, along with p53, BCL2 was two other examples among other ones. The sort of the research in the retinoblastoma protein early on led to one of the major discoveries in cancer causation research, which was two-hit theory by Knudsen in the 70s. And this is a very simplified diagram of this, which, one mutated gene is not enough to sort of trigger the disease or trigger the progression of the disease. This is in a somatic setting. You need two somatic events to lead to the two-hit theory to be activated. However, in the hereditary setting, where patients are born with one germline mutation, all it takes is one event of a somatic mutation, and that leads to the disease not being counteracted. which is also labeled as loss of heterozygosity. In terms of DNA repair genes, some of the ones I'll be talking, this is a list of some of the ones I'll be talking about. I mean, you'll notice as I go through some of the studies which are covered in prostate cancer, really the bulk of it, or the ones that are really in the forefront of this, are the BRCA 1 and 2 in particular, MSH2, which is also involved in Lynch syndrome, ATM, and CHEK2. The others are also will be covered, but these really are the main candidates, so to speak. So moving on to prostate cancer. So in localized disease, it was found that patients with DNA repair genes are anywhere from 4 to 8%, depends where you read. But this is a breakdown of sort of one of the more recent examples of these type of studies where they screen patients for DNA alterations. And we see the majority of them are sort of between ATM and BRCA2, BRCA1 to a lesser extent. And this is the incidence in metastatic disease, and this is one of the seminal papers by Pritchard in 2016. And we see the incidence is somewhere between 11 or 12% in that pool of patients. And again, we see BRCA2 and ATM and CHEK2 are really on the forefront of this, comprising most of the mutations in this field. And this is just a little diagram to show the differences. So yeah, 11.8% in metastatic disease and just under 5% in localized disease, but it can go up to 10% in some papers. And similarly with metastatic disease, some have described up to 18%. So what are the clinical implications of finding germline mutations? I'll start with screening in prostate cancer. This is the IMPACT study, which was published, or an updated version of it was published in 2019, which what they did is they screened just under 3,000 men with the BRCA 1 or 2 mutations, and then they screened for prostate cancer. And about 230 men met the criteria for screening, which is a PSA above 3. These men were sent to biopsies, and cancer was found in 48 BRCA2 patients versus 15 in the non-carriers, and 31 BRCA1 patients versus 19 in the non-carriers. The majority of the BRCA2 were intermediate disease. We see here 77% of intermediate or high risk disease versus 40% in non-carriers. So that does show us that these patients harbor worse disease than the general population. The positive predictive excuse me, the positive predictive value in BRCA 2 population was 31%, which is significantly higher than the remainder of the population in this study. This is just a breakdown of the different populations they used. They used BRCA1 and BRCA2 negative populations as control for each group. And we see here on the far right, in the carrier group, BRCA1 didn't really show significant differences compared to the cohort, but in BRCA2, we see there's a significantly different, at least in the positive predictive value of having a PSA of more than 3. This is another breakdown just to show how much worse the disease is in BRCA2, and we see here high and intermediate risk, and the top comprises about 77% in carriers, and we see here even the incidence of Gleason 8 in BRCA2 is about 13% compared to the others, which are significantly less. So what does that mean? It takes us to the next step really in this population, which is active surveillance. So what do you do with these patients once you've diagnosed them? This is a paper that was published last year in European Urology by Carter and colleagues that looked at germline mutations in the BRCA carriers plus ATM. And they found that they were associated with reclassification while they're on active surveillance. This was about 1,200 patients on active surveillance, and of these, 26 had mutations. And this is going to be a common sort of recurring theme in most of these studies, that these patients or the samples are very, very low number, 26 and 13 and things like that. We'll see later in the remainder of the talk. But they had a median follow-up of 3 years in this cohort, and the hazard ratio for grade reclassification for any gene carrier was 1.96, and for BRCA2 carriers in particular was 2.7. There was also a higher incidence of Gleason 4+3 in the BRCA2 versus 3+4 in the remainder of the cohort. And the limitation here, obviously, is the outcome does not really, or the endpoint does not really reflect longer outcomes. So we don't know yet if these patients do worse or not, at least in this cohort. And obviously the risk of misclassification from the original biopsy. If we look here at the 5-year risk of upgrading, you'll find that it's 41% versus 22% in any gene carrier compared to the rest of the population. Then when we look at BRCA2 alone, it's about 50% at 5 years. Similarly, there was a higher incidence of upgrading from grade group 1 to grade group 3, as mentioned earlier, in 4.1 versus 0.7%. Obviously, all these differences were statistically significant in this paper. So once they're diagnosed, we know it seems like their prognosis is worse. And this paper in 2017, also published in European Urology, looked at the same genes, ATM and BRCA1 and 2, and they looked at it from a prognostic point of view, whether they're able to distinguish between indolent disease and aggressive disease. And in their cohort, they had just under 800 patients, including 313 which had passed away from prostate cancer. They looked at these alterations in both localized and lethal disease, and the incidence of carriers was 6% in the population that had passed away, versus 1.4% in localized disease. And there was also it was also noted in this paper that there's earlier death. These patients were younger versus controls, and the mutation carrier status was an independent predictor for death from prostate cancer. You see here in these two charts which shows us diagrams, which show us a mutation carrier versus a non-mutation carrier, and this is for cancer-specific survival. We see the curves splitting quite rapidly from early on, and so this takes us to the impact of carrier status in localized disease. So what do we do once they're diagnosed, and how do we treat them? This paper was published last year, in 2020, by Wu and colleagues, and looked at rare germline pathogenic mutations of DNA repair. And they found that they were strongly associated with grade group 5 prostate cancer. They had about 1,700 patients that underwent radical prostatectomy, and what they did is they compared grade group 1 and grade group 5 and gene panel, which they screened for in this cohort. They found that 8.4% of gene carriers in the high-grade disease, in the high-grade group, so grade group 4 and 5, versus 3.5 in the low-grade group, and this was significant, statistically significant. The main genes that were found in this cohort were BRCA2, ATM, and MSH2, and the incidence was 13 versus 3.5%, just looking at these three, so it's a little bit higher than any gene carrier. The odds ratio was 20 for these three in particular, for harboring grade group 5 disease. And the same three genes were also independent predictors for metastasis and death, which was 7% in this cohort. And if we look at localized disease alone, this was one of the earlier studies by Castro and colleagues that came out in the JCO in 2013. They looked at just BRCA, because at the time that was sort of the more popular, or the one that we knew more about They found that it's associated with higher risk of nodal involvement, distant metastases, and poor survival. So this was a cohort of 2,000 patients, which they found about 79 patients with BRCA mutations, and they were treated with either a radical prostatectomy or radiation. And they found that carrier status was actually associated with higher Gleason score, more advanced or locally advanced disease, and N-positive status, and ultimately metastasis. And in these four groups, they found that it was statistically significant across all these, all the ones I mentioned. And cancer-specific survival was also significantly different. It's at 8.6 years versus 15.7 years for carriers versus non-carriers. So there seems to be a trend developing here towards these patients faring worse. I mean, look here at the Kaplan-Meier here for overall survival, and you can see BRCA2 in particular fares much worse than non-carriers and BRCA1 carriers. And we see here on the right that BRCA for overall survival is a strong predictor for metastases, for overall survival, almost as bad as having Gleason 8 in the non-carrier group. Similarly, for metastasis-free survival, we see that these BRCA2 carriers also significantly worse than BRCA1 and non-carriers. And we see here on the right that's almost carries the same risk for metastases as someone diagnosed with the Gleason 8 disease, the non-carrier. So the treatment outcomes of these patients were also looked at by Castro again in 2015, and they looked at BRCA mutations only in metastatic relapse and cause-specific survival after radical treatment with either radiation or prostatectomy. Their cohort comprised about 1,300 patients with either localized or locally advanced disease, and the total number of BRCA mutations was 67 patients in this cohort. They were followed for 64 months, and there was a higher T stage in carriers versus non-carriers, higher grade, and higher nodal involvement, as mentioned earlier, 6% versus 2%. Their survival at 3 years was 97 and 90% for carriers and non-carriers, and then 94 versus 74 at 5 years. And then at 10 years, it drops to 50% for carriers. Similarly, for metastasis, we see here 90 versus 97% for the metastasis-free survival, and at 5 years, it's 72% of carriers, and again, 50% for carriers at 10 years. So it seems to be more aggressive and more rapidly progressing in carriers versus non-carriers. And in this cohort, also BRCA status was an independent predictor for worse cancer-specific survival. We look here at these Kaplan-Meier. A shows us just metastasis-free survival in all comers, and we see clearly carriers faring much worse than non-carriers. However, when we look at the radical prostatectomy cohort here in B, although they're doing worse, but compared to radiation, there seems to be some difference here between these two. Admittedly, the numbers are low, but we can see a trend developing here. Similarly, with the cause-specific survival for all comers, again, carriers or mutated, the mutated population does fared a little bit worse. And we look here at radical prostatectomy cohort within this. Do fare worse, but later on, however, with the radiation, we see a rapid drop here in the curve, an earlier splitting. What about recurrent disease? This was looked at in this paper published in Prostate in 2018, where they looked at 150 unselected patients with recurrent or metastatic disease tested for germline mutations. Their total mutated patients were 21, again, very low incidence. And they found no associations between germline mutations and age, tumor stage, and Gleason sum, or even family history in this cohort. But they found that they were more likely to harbor intraductal histology. 48% of these 21 patients had intraductal versus 12% in the whole population. Similarly for LBI, and just under half of the patients who tested positive would have not been offered genetic screening according to NCCN guidelines, which came out 1 or 2 years ago, just by looking at family history. So this started raising the question of who do we screen, which I will get to shortly after we talk about metastatic disease. This is just a breakdown of what genes were associated with the worst outcome here, and the majority of them, or the ones that are always in the forefront, study after study, are the Brca family, CHEK2 and ATM. And then we move on to metastatic disease. So incidence of germline mutations in this group is higher than localized disease. It's close to 12%. Some other studies report a number that's a little bit higher, up to 18%, I think, in one series. What Pritchard and colleagues did here in this paper, they looked at 692 men with metastatic prostate cancer, and they used a 20-gene panel, and they found that the incidence was significantly higher in metastatic versus localized disease, and that difference was statistically significant, and they were not associated with family history of prostate cancer, which was similar between both groups at 22%. However, they did also find out that family history of breast, ovarian, or pancreatic was significantly higher in carriers versus non-carriers. And this is a breakdown of which genes were also encountered. And again, the same group, BRCA family, CHEK2 and ATM. Yadav and colleagues in 2019 looked at the contribution of these genes and mutations in hormone sensitive in castrate sensitive and castrate resistant metastatic prostate cancer and implications on clinical outcome. They had 740 men with metastatic disease, 220 with that was castration sensitive versus 480 that's castration resistant. They used a 21 gene panel to screen, and they found 9.4% of their population who had mutations, and they discovered 12 genes. Again, ATM, BRCA2, and CHEK2 are really the main ones, or comprise the bulk of these patients. Frequency of mutations was actually higher for some reason in this cohort in the hormone-sensitive group versus the castration-resistant group, but there was no statistically significant difference there. And in terms of going into or moving into the castration-resistant state, the difference here was not found to be statistically significant, although we see here it's 23 versus 32 months. And in this study, there was no association with worse outcomes. And they looked at overall survival in these groups. The first one on the left, or A, is all comers, and and in B they looked at overall survival between carriers and non-carriers, and only in the hormone sensitive disease, and there was no statistically significant difference here in overall survival. Similarly, in the castration-resistant population with who are mutation carriers versus non-carriers, again, not a statistically significant difference in this particular study. And if we look at the castration-resistant population and their treatment outcomes, in this paper published in 2018 in European Urology, they looked at germline gene mutations and outcomes in that population, particularly the ones receiving first-line ABI and enzalutamide. They had 172 patients with 12% incidence of DNA damage repair mutations. ATM and BRCA obviously in the forefront again, and the incidence was about 5% for these two in that population. They were younger at presentation with a higher incidence of more locally advanced T3, T4 disease. And their PSA response was actually for a drop for more than 90% was found to be 59% in carriers versus non-carriers. And a multivariate analysis in this study showed a longer PSA progression-free survival in BRCA and ATM carriers versus non-carriers. And we see here in the Kaplan-Meier analysis for PSA progression free, it seems like these carriers fared a little bit better than non-carriers in this particular study. Also, the overall survival was not statistically significant between the two, although we see a split in the Kaplan-Meier survival analysis here. Moving on to another paper that sort of reported the impact of germline mutations on outcomes of the same group. They had 419 patients and aimed to assess the impact of ATM, BRCA, and PLB2 on cancer-specific survival compared to historic cohorts. Incidence of carriers was about 16.2%, and cancer-specific survival was 23 months versus 33 months, which was not statistically significant here. However, for BRCA2 alone, it was in this group 17.4 months versus 33.2, and that was that's a big difference. And the BRCA group alone also had worse cancer-specific survival when they started on a taxane treatment first versus androgen receptor inhibitors first. And they also found that BRCA2 status was an independent prognostic factor for cancer-specific survival. This is a paper by the UBC group, which looked at treatment outcomes and tumor loss of heterozygosity in patients with germline DNA repair in prostate cancer. It was 319 patients with metastatic castration-resistant disease, and 22 DNA repair gene panel was used to screen these patients. And it was actually the first paper in this sort of research field to report or evaluate the PSA response to ADT in this group. And the incidence was 7.5% in this group, 16 of which were BRCA2, 16 out of 24. So really the majority of them were BRCA2. Progression to castration resistant in the carrier group was 11.9 months versus 19 months. This is from starting ADT. And progression on ENZA or ABI was 3.3 months versus 6 months in non-carriers. However, when they looked at progression of on docetaxel, the difference was not that significant, neither clinically not specific statistically. And BRCA2 carriers also expressed loss of heterozygosity on circulating tumor DNA, which was concluded that this could help prioritize some patients to more precise treatments. And this is another publication also by the group in UBC about circulating tumor DNA genomics that correlated with resistance to ABI and ENZA in prostate cancer. It was looked at, it was more of an exploratory analysis that looked at a cohort of 202 patients with metastatic castration-resistant disease that were naive to treatment. They were randomized to ABI or ENZA. A 72 gene panel was used through circulating tumor DNA. And the time to progression in both the ABI and the enzalutamide group was similar. However, the initial response in the ABI group, in the ENZA group was more rapid. And in a multivariate analysis of these alterations or germline alterations in homologous recombination repair genes, BRCA2 and ATM in particular, also in tumor suppressor genes P53, they all remain significantly associated with shorter time to progression. And the bulk of the patients with BRCA2 and ATM that were available, that had ctDNA available for analysis, had a detectable loss of heterozygosity in their liquid biopsies. And this is just a quick or small paper that looked at association between BRCA2 and sensitivity to platinum-based chemotherapy. They had 144 patients post-docetaxel that were started on carboplatin and docetaxel, and 8 out of those were BRCA2. And they had a 75% PSA decline below 50% in carrier versus 17% in non-carriers, which really starts raising the question of whether these patients could benefit from receiving platinum-based chemotherapy in prostate cancer. There was another paper that was published in 2012, also in British Journal of Urology, that looked at the same thing, but with docetaxel in that population. There were similar numbers, patients in just under 200 in that cohort that had 7 of BRCA2, and there was no difference noted in their response with docetaxel. The reason I included this one is just for the more rapid PSA response to the combination of carboplatin and docetaxel. And which really moves us to more recent work, which is response to therapy. And we look at olaparib here for DNA repair defects in metastatic prostate cancer. This TOPARP-A study, which was a phase 2 PARP inhibitor study, they looked at 50 patients with castration-resistant disease post Abi-Enza or cabazitaxel, so second-line treatment, assessed for response to olaparib, which was defined as more than 50% reduction in PSA, and the response rate at the time was 33%. And the response in the BRCA and ATM population was the highest amongst the other mutations, which led to TOPARP-B study, which came out 2 years ago in Lancet Oncology. They looked at 711 patients with castration-resistant disease, and they had 161 that had DNA damage repair aberrations. They were randomized to different doses of olaparib, and the incidence of, or the breakdown rather, of these patients, about a third had BRCA2, about a fifth had ATM, and less CHEK2 and BRCA1, which follows suit really with all the other papers, with BRCA and ATM being at the forefront of this. They had all received docetaxel previously, and the response rate in the BRCA family was similar to TOPARP-1, which is 30 to 35% between BRCA1 and 2, and also a 22% response in the ATM group, similarly about a third in the CDK12 carriers. However, this was at the higher dose, the 400 milligram dosage. And this takes us really to one of the big trials in 2020, which was the PROfound phase 3 trial, which looked at survival with olaparib in metastatic resistant prostate cancer. They had 380 patients with the castration-resistant disease that were randomized based on their alteration status. So it was a 15-gene panel, and the way they grouped the patients is BRCA1 and 2 and ATM in one group, and then the other 12 in the other group. And they were randomized within each group. They were randomized to either olaparib or standard of care, being abiraterone or Enza. In cohort A, which was the ATM and BRCA group, the median overall survival was 19 months versus 14, which was statistically significant for olaparib versus standard of care. However, in cohort B, which is the other 12 genes, the median overall survival was 14 months versus 11.5 months, and this was not statistically significant. We see here their Kaplan-Meier charts here for the median overall survival. The top one looked at the ATM and BRCA population. So just to put it all together, these gene carriers in prostate cancer seem to be faring worse in almost every aspect compared to non-carriers, which really brought in the question of who do we screen and when do we screen them and what do we do once we screen them. We see here one of the updates or the updated NCCN guideline for genetic and familial high-risk assessment. For some reason, prostate was included under the breast and ovarian and pancreatic disease, but the recommendation, in short, was to screen patients who were found to have intraductal or cribriform pathology, family history, personal history of any Gleason 7 or more, or a close relative with ovarian, pancreatic, or metastatic prostate cancer, 2 relatives with breast cancer or Ashkenazi Jewish ancestry. They also advocate for screening anyone with metastatic prostate cancer, which this led, at the same time, there was 2 consensus statements that were published from the Philadelphia Prostate Cancer Conference. And they really summarize what the recommendation is. It was a large panel of experts that looked at which men should be considered for germline genetic testing. And we see here that they do recommend for men with metastatic disease to be screened, and for all the other groups for it to be considered. So in advanced disease, intraductal pathology, and anyone with grade group 4 or above. Similarly, in the family history, patients who carry some family history of prostate cancer, it is recommended to screen anyone with a diagnosis of prostate cancer less than 60 years old, or anyone who has family history of death from prostate cancer or metastatic disease in the family. Similarly, any family history of 2 or more cancers from sort of breast, ovarian complex, or Lynch spectrum. So what panels should be used when we screen these patients, or how do we screen them? In metastatic disease, obviously BRCA family is in the forefront, and mismatch repair genes like MSH2 and MLH1 were recommended. ATM is to be considered, and they also suggested a tailored approach in these patients to test genes based on personal or family history. In a non-metastatic setting, BRCA2 is recommended, especially to inform patients on active surveillance. However, ATM is only to be considered. And the third question that they addressed in this consensus was prostate cancer specific recommendations that should be considered based on finding genetic testing. So in the metastatic population, they recommend enrollment of these men into precision medicine trials, and particularly for BRCA2 and 1, as they may inform a response to PARP inhibitors, and to consider it for platinum-based chemotherapy as well for BRCA, for the BRCA family. There is a recommendation to consider the patients with Lynch or mismatch repair genetic defects for PD-L1 and PD-1 therapy. And in the non-metastatic setting, it's just to discuss active surveillance to recommend BRCA2, as we know from the paper we discussed earlier that they tend to fare much worse than the remainder. And for men without prostate cancer diagnosis, is referral to specialty high-risk prostate cancer clinics or early detection trials is recommended. Similarly, they recommended early detection at 40 years or 10 years before youngest prostate cancer diagnosis in the family, to look at BRCA2 and also mismatch repair genes. I'll move on to talk a little bit about urothelial cancers. When I started looking at this, I mean, there isn't a huge amount of work done yet. I mean, it seems like it's still in its infancy from a research point of view, but when you start reading, there's a lot of commentary about substantial hereditary component in this disease. And I remember when I sent it to Dr. Black, his comment was, we don't really see urothelial cancer families, certainly not like prostate cancer, but I think this is primarily based on a large twin study, which they found a hereditary component in bladder or upper tract cancers in up to a third of those. And apart from Lynch syndrome, there isn't really much else that's well defined in urothelial cancers. We know mismatch repair genes in MSH2 and MLH. One have a cumulative risk of bladder cancer of 12.3% in men and 2.3% in women. However, there's no large systematic evaluation of these mutations in urothelial cancer. Few efforts were made for targeted sequencing of known cancer susceptibility genes that revealed anywhere from 14 to 24% prevalence in urothelial cancers. This is a study that was published last year in Cancer Susceptibility Mutations in Patients with Urothelial Malignancies, and they had a population of 580. They performed a 77 gene panel, and the incidence of germline variants that could be pathologic or likely pathologic was 14%. 83% of them were DNA damage repair genes, and the main ones were BRCA2 and MSH2, as they were significantly associated with increased risk. The odds ratio was 3.7%, and that was statistically significant. Excuse me. And when they looked at the guideline recommendation from Lynch population, they found that in this particular cohort, they would have failed to identify 26% of patients, which really raises the question of how do we screen for them. This is just a breakdown of the incidence, and we see MSH and the BRCA family being at the comprising the majority of these, or at least a third of these patients. And here we see the breakdown of the different mutations and association with either upper tract urothelial or bladder cancer. And again, MSH2, we see significantly higher upper tract involvement in those patients. Also, another study that was published 2 years ago that looked at germline mutations in DNA repair genes in particular that were associated with bladder cancer and risk of unfavorable prognosis. This was 98 bladder cancer patients from China, and they had a 54 DNA repair gene panel, and they found the incidence to be 10% for pathogenic germline repair mutations in bladder cancer, and 2.9 in an unselected cohort that they used for control. Also a higher incidence in muscle-invasive disease versus non-muscle invasive disease. And they also found that there's an earlier onset in these patients, as 1/4 were before the age of 45 versus 8.8% in non-carriers in the control cohort. Amongst carriers, about half of them had a recurrence or progression, so it was associated with worse performance in the disease. This is the list of the mutations that were highlighted in this group. And on the right side here, if we look at progression in the non-muscle invasive group, we see a statistically significant difference. Mind you, the numbers are low. The carriers were 10 in this cohort, sorry. And this is another paper that was also published last year showing the prevalence of pathogenic germ cancer variants in high-risk urothelial cancers. And about 1,000 patients with urothelial carcinoma. They used a 17 gene panel to screen, and the incidence here was 24%. And MSH2 and BRCA family were the higher incidence compared to others, which included other MMR defects and ATM. We know from the work done in Lynch syndrome that MLH1 and MSH2 in particular in urothelial cancer are actually actionable alterations, but this study concluded that ATM and BRCA2 could potentially be actionable variants. And this is just a table highlighting the incidence of the different genes, and we see MSH2 is really at the again at the forefront of this Fanconi was detected in a significant population, but with low penetrance. And we see the BRCA family combined gives us 4.4% with high penetrance as well. And if we look here at the different genes and the incidence of urothelial carcinoma, we look at MSH2 probably has the highest in relation to the others. But if we also look at the BRCA family here, we see that the combination of 1 and 2 also has a significant incidence of urothelial cancer. And this is just an enrichment of DNA repair gene variants. And we see the MSH2 is really frequent on the far right here, similar to MLH1. BRCA and ATM are slightly less frequent, but certainly of importance in this population. And they also looked at therapeutic implications in these patients, and the presence of DNA damage repair mutations in 47% of the PDE1 and 25% of PDL1 is associated with higher response rate inhibitors, 68% versus 19%, and this was statistically significant. This is another paper which came out last year in Nature Communications, and this sort of tried to define the lay of the land in this research arena, as not much work has been done prior to that. So what they did is they looked at 80 patients with urothelial cancer, of which 82% were metastatic, and they harbored a total of 157 tumors. They compared their wide exome sequencing to the TCGA cohort for bladder cancer, and looked at both for putative deleterious germline variants. Overall, there was 56% who had germline variants in this cohort, and many of them were truncated tumor suppressor proteins. And the most frequent genes harboring these were ITGA7, POLQ, KLK6, and EPHB6, occurring in 11 out of 45 patients, which brings the incidence to 24%, not that different from what we already know. And they also examined the impact of germline variants and loss of heterozygosity in both the primary and the metastatic disease. And they found 28 germline variants that were available for analysis in both primary and metastatic tumors. And they found that 96% of those 28 patients had clustered with previously reported somatic variants, and half of them showed evidence of loss of heterozygosity. And when they followed them throughout the study, looking at both primary and metastatic tumor pairs, it showed that 23 paired comparisons, which comprised 79%, exhibited significant variant allele frequency increases in the metastatic tumor. So basically, they looked at the interactions between germline and somatic mutations in this, and the loss of heterozygosity. And these genes that were highlighted earlier were significantly associated with these interactions. So we tried to cover prostate and urothelial cancers in this talk, and obviously not much going on yet in the urothelial cancer, but a lot of major work was published in the last 5 years in the prostate, especially metastatic castration-resistant prostate cancer. So just to conclude and give a few messages from this talk, germline alterations is a growing research field. It still remains a complex topic, not very well elucidated, certainly not yet in day-to-day practice, and certainly not outside prostate cancer. There's a clear difference in the clinical course of localized and metastatic disease with germline alterations in prostate cancer, which raises the question in the context of screening and cascade screening, and how do we how do we perform active surveillance on these patients and whether they would be a candidate for active surveillance or not. And although I say here possible, but it's the likelihood of these patients requiring a multimodal approach in localized and metastatic disease. We know that there's a favorable response to PARP inhibitors in these patients, especially in metastatic prostate cancer. Will it play a larger role further down the line in earlier stages with BRCA carriers? That's to be found. And not much going on in the urothelial cancer, and there's a possible favorable response to platinum-based therapy. There was one study that illustrated that, and I think there should be something out soon on PARP inhibitors in this arena, but I don't think there's a lot of mention of it in some of the presentations, and the publications, but I haven't come across it yet. And screening for germline alterations in our clinics, I think, will be integrated in the near future. Thank you very much for listening, and I would also like to thank Dr. Black and Dr. Gleave for guiding me through this talk.